Well, we hope we've provoked you a little bit in the clips that you've seen and in this really, heartfelt and very thoughtful discussion on end-of-life issues that are not always easy for us to talk about even in 2012. So now we're going to open it to you. We have 2 mics, one on each side. If you have any questions for the panelists, please feel free to ask questions. I know that because we've shared some of our stories, that what stories do is they open the floodgates. So I ask that when you come up, that you ask a question. We're certainly, respectful of your own experiences, but we ask that you direct them to specific questions of the panelists. Yes, please. And please say your name.
Yes. Hi, I'm Terry Nicoletti. I'm an actor, and I'm very, very honored and grateful to be here. I'm very moved by people at your level of influence and expertise dealing with this issue. I want to know, while you're doing all this work and encouraging work around patients and doctors changing their attitudes, somebody's making profit off of all that money that's being spent at the end of life. My aunt was in her late 80s, and my cousin decided no feeding tube, and the doctor said, well, you don't want to starve your mother to death, do you? And I thought, how much money do they make on that feeding tube? So could you please address, is there pressure from that side against what you're trying to do? And if there is, what can we do about it?
Dr. Foley.
Well, in a way, there's a little bit of a danger about this because there's one now randomized controlled trial that demonstrates that palliative care saves money. And there's 2 others that will shortly be published. So we're a little bit, we don't want this to be only about the money. There's so much more at stake here. But the study was in a group of patients with stage 4 lung cancer, and basically the patients were given concurrent cancer treatment with a palliative care consultation team. And the ones who received that care ended their chemotherapy sooner. They lived longer. They had a better quality of life. They were less depressed. But it did save money. And so one of the difficulties that we've had with advancing palliative care is that some people see it as second-class care, that it's not the Cadillac of care that they wanted to receive. So this is another educational societal balance. So yes, there are incentives, but I would say in the medical, I think we're now coming to recognize that we need appropriate medical care, we need evidence-based care, and we need to be able to balance this issue of how do we hope for cure, how do we achieve cure at the same time that we provide care. So making the money the only issue, which is driving now advances in palliative care, is a little dangerous.
But it's interesting because we should get those stories out, as you just said, about what was the difference.
Yeah.
Why did those people feel better?
Yeah,
what did they experience?
Right. And when this paper was published in the New England Journal of Medicine, it had extraordinary press coverage. And that day, to my colleagues on the palliative care team there, everybody was asking for a palliative care consult because they heard you could live longer.
But I think what you're saying is really important because we need to have those stories ready.
Yeah.
When we're releasing these kinds of studies.
Yeah. Right.
So that when we have a study that says that,
Absolutely.
We can have that person who, or their survivors, if they've
tell the stories.
To tell the stories, and that will, I think, help to connect us more and show that it's more than just money, which is important because it is so expensive and we're spending so much, but it's more than that too. It's their quality of life was better, and here's why. And we can then hear that and relate to it, as opposed to just, as I said before, just those numbers.
This whole panel has focused on how powerful and moving and aesthetically full of pathos, these movies are. But one aspect or dimension that we haven't talked about is the power of film and television to criticize the way healthcare is delivered. There's an enormously powerful scene in the movie Wit where Emma Thompson has signed a do not resuscitate order, and the gung-ho fellow that ignores it and calls a code on her. And it's not until the nurse you saw there splitting a popsicle with Emma Thompson knocks him down, physically confronts him and knocks him to the floor, that he comes to his senses. So there's a power in film to criticize social issues too.
Absolutely. We were criticized by the New England Journal on ER the first year for showing that cardiopulmonary resuscitation was too effective.
Yes.
And I took it to heart. And I did an episode where Noah Wiley resuscitates an elderly gentleman and breaks his ribs, punctures his lung, but boy, he got him back, and then leaves the patient to Juliana Margulies, who's like, what has he done?
Right.
And so it really illustrated that the point that you just raised, and we did get a lot of feedback, like, wow, because people get their health information from television, from the internet, and so we want to be honest and accurate.
That was a great one.
Hi, I'm Joanne Lynn. I'm with the Altarum Institute Center for Elder Care.
And also a major leading expert on end-of-life care. You should answer the economic questions.
I'd be glad to, but I rose to ask a different question. Just invite you to try out thinking about why it is that the most common way to die, we still haven't found language or image for. Look at this audience. Half of us will die mainly with frailty. We'll be very old, we'll be very disabled, we'll be relying on people for not a month or two, but for years. Many of us will need a nursing home, a quarter of us will be demented. There were a few seconds there of Iris, which is, I think, the only popular film or semi-popular film that kind of dealt with that. 50 years ago, that way of coming to the end of life was so uncommon as to be dust in the system. We built Medicare at a time when people got sick and died. They got sick. Marcus Welby said, terrible things. They struggled with it for a while. But mostly the course from knowing you were very sick to being dead was on the order of a couple of months at most. I mean, it was kind of a grace if you got that long. Now, most of us will live a long time with the uncertainty of when something will be big enough to cause our death. Death is almost sort of an afterthought. I mean, it's sort of like, why didn't she bother dying last month, But the struggles of the caregiver, you talked at one point about how you like to see people very low on the hierarchy. I mean, the people I'm speaking about, the caregivers to them aren't even at the medical meetings. The direct care workers in our country aren't even protected by fair labor laws. There's a whole group of people that most of us are going to rely on, either for ourselves or for someone in our family, who don't even have a voice. And we don't tell those stories at all. We have a book called The Handbook for Mortals, and over and over again, people come up and say, we really appreciated this book. It got us through, our mother's dying or something. And they say this very interesting phrase. They say, it gave me the words. And you realize that there isn't popular culture words or images. What do we know of Ronald Reagan dying with dementia? Nothing. What do we know about the struggles of people living with people 96 or 98 and who, need help to get to the bathroom and frequently have accidents? And we are going to live to be those people, and we have not the language or the stories or the images. Why can't we go there? The stories that are up there are lovely, and I'm so glad they're there. They weren't there 20 years ago. So, I'm glad they're there, but there's still yet another frontier. Mm-hmm. And it's not a trivial one. It's the fate of most of us. And when are we going to learn to talk about what most of us will travel through? Think about it a little and tell us what you think. How can we get there?
Well, Kathy told us just now, or a moment ago, about dignity and ways of sharing our stories. And I'm seeing things on YouTube channels and Pick TV and places we didn't have before, where we're talking about everything from what it really feels like to be a teenager who's pregnant to end-of-life issues. So I think we do have this frontier that's open now, and it's not expensive to make these kinds of programs. The cameras are pretty inexpensive. So it's really, I think, it would be interesting to know, because I haven't looked myself, what's on YouTube now? Is anyone doing it? But I imagine that that would be something, that various foundations and others can start to support, because it's not really expensive, and we can start to tell those stories. Do you have thoughts about that, Jay?
I think you said it well.
But it's there, and it's there for the future. And a lot of young people, particularly, already watch webisodes, and now. So I guess that's a challenge to you. How are you going to put those stories? Because you've seen those stories. It's not as hard as it used to be. You don't need multi-million-dollar sets and cameras and things like that. So it's a matter of kind of putting it together.
I live for the Golden Girls coming back. With all the characters 20 years older, quite disabled, and cracking jokes about sex.
Well, I think you should make that. Unfortunately, the actor, not as life, all 3 of the 4 are deceased, but you could certainly do some kind of show like that. Yes.
Hi, my name is Elizabeth Phillips. I'm actually a resident in emergency medicine at GW just up the street. And in the very limited experience I've had in my medical career so far, I've been truly disturbed by how poor we are at allowing patients to have a good death. And I think one of the primary barriers to that is either the caregiver and family not giving permission to the patient to die the way they want, or the actual medical provider not being able to allow the patient to die. And I wanted to ask the panel what they thought was impeding those people from letting the patient do what they wanted. Is it their own inability to address death themselves? Because I also have a master's in bioethics and a particular interest in death and dying. And as a physician, I'm really astounded how few of us have thought about our own death and how we would prepare for that, and how we would expect to be able to talk to a patient or a family member when we haven't even reflected ourselves on what we would want done. So like I always do this, how many people here in the room have an advance directive like right now? Okay, so this is a biased sample, but for the majority of the times that I do that, usually it's like, 2 or 3 of an entire group of physicians, and I think that that's something that we should think about and a place that we would start. But I'm curious as what you think about the, barriers to the providers and caregivers to thinking about death and why they avoid it.
Thank you. Brian, you've lived it and seen it from many views, so what are your thoughts of that?
So I do a lot of performances in medical communities and medical schools, and one of the questions I ask, perhaps the most controversial, is what do you really feel or think about what would be the right thing to do if a patient asked you to help him or her to die or end their pain in some specific way? Because the play models it, and it raises all those ethical questions. And by the way, in the time the play was being performed, doctor-assisted and assisted suicide was common, and the Hippocratic folks, the Pythagoreans, that very fringe group that wrote the oath, were marginalized. And then 2,500 years later, we saw who wins that battle, at least for now. And what I get back as an answer is usually a legal answer, and someone usually lectures me about the double effect and tells me as if I don't know about the double effect, and I've been in enough places to know about it. But it feels like that's the 800-ton gorilla in the room, and then maybe 1 or 2 people will move past the legal answer or the answer that they've practiced or been sort of told to say, and in spite of the risk it is for in front of their community to say it, talk from their guts. I think it's about creating a safe place for physicians, especially during their training, and then afterwards, as they're having modeled for them by other physicians' attitudes about this issue, to be real and to speak the truth. to one another in terms of what they're feeling and get past the legalities and get down into the ethics. I don't think we have a space for that in our current medical curriculum. But until doctors can be real and talk about it, I don't think we can expect them to be real with their patients.
Yes.
Yeah, hi, my name is Lena Slackmulder. I work with an organization called Search for Common Ground, and we use theater, television, and film in war and conflict-torn countries all over the world, precisely like you said, to open up difficult conversations and point a way towards people to have the words and the skills and the models to deal with things. And we've seen, in this country, relationships portrayed on television have shifted social norms, racial norms, recently gay and lesbian issues. And I'm wondering, in the way that you are producing television programs around the subject, are you trying actually to push things further? You mentioned, Neil, how they edited that clip and showing you pick up the hand, you take off the mask, you do these things. Are you actually deliberately trying to skill your audience to have these conversations and do certain things in a way that's different from the generation? And do you ever get into dialogue with your audience, both normal people and medical people, to know whether or not that's helpful or it's just good drama?
Mm-hmm. Well,
Yes.
I think it depends on the producers and the writers of the show. So some shows just reflect what is currently happening. So these topics are discussed a lot. And so they're reflected and refracted through the writer's experiences. And we do try to give writers through various organizations expert information so that they can be as accurate as possible. But when it comes down to how we structure a show, it becomes very much about the person. And so because I'm a physician, I've really pushed a lot of issues. I did a show up on, euthanasia. I was able to write it in a certain way where we just put the issue out there, which was, a mother with a child with Tay-Sachs, and what should someone do? Or on vaccinating your child, and that child isn't vaccinated, and the child exposes another child to the measles. It all comes out of my experience. So we do sort of encourage, and I talk to young physicians to come and write with us, to bring their experiences, because that is a great way. We're doing some work at UCLA we're going to with fourth-year medical students, where we tell them to take their private story, the story that's really affected them, and make it public through blogs, op-ed pieces, Twitter, whatever it is, so that the discussions can get out there, because they're living really profound stories. And so we're trying to think of new ways to do that. But it's very challenging, and certainly everything is colored by our experiences. But we want to broaden the experiences as well. So unfortunately, we're out of time. It's been really quite enlivening for me to hear the three panelists' perspectives, and it's given me thought about what I can write about in the future, and I hope it's given you some thoughts about how you can share these ideas. I'm going to ask each panelist just very briefly for a moment just to share one last thought with you before we wrap things up. We'll start with Brian.
Oh, man. Well, I've shared a lot of personal details, but recently when my wife and I had our first child, we had not a doula during the process of birth, but a doula when we came home to our apartment in Brooklyn, and that doula helped us with the transition to life. And it occurred to me that we really need death doulas. This is an apolitical issue. We need people who can guide us. In ancient cultures, there were people who served this role. And I think there is an industry to be built around it, and I think it's a vital role that a lot of people have the skills to fulfill. They may be marginalized now, but my feeling is, to the question that was just asked, as the baby boomer generation ages into senescence, as my parents' generation, and wants to die with dignity, I imagine the next time we have this conversation, if it's 10 years from now, this will be a waiting, standing room only audience, and I imagine that'll drive a lot of the conversations that'll be happening on television and the film as well. I think it'll be the lasting contribution of the last contribution the baby boomer generation makes socially is to drive this this issue to the fore and maybe hopefully bring it to a national consciousness.
I think that the healthcare professionals need a lot of help because they can only, in a way, be where society is. And so for Americans, remember that, death is always a second choice. It's give me liberty or give me death. And so we have to change that first. And so we have to somehow or other balance this extraordinary desire for cure with a desire for care. And how do we balance that? And balancing it is by having the Institute of Medicine think that this is an important topic that needs to be addressed. We need it balanced by having the economics of it in favor of supporting this and understanding what the incentives are. But at the very, very human level, it's one person, one family, one individual reflecting on this. So I think we need a lot of death talk.
I'm struck by the enormous barriers to what we're trying to do. I'm really moved by the different efforts that each of my fellow panelists have made, and I see they have great effects, but I also think that there are really entrenched barriers to dealing with these issues. In the medical arena, there's a powerful impetus to not go this direction. When you think about the arts and the humanities in a medical school, you think about something that's soft, something that's fuzzy, something that is a little add-on or an extra. And in some ways, I don't blame them, because until we come up with a way to demonstrate the real effects of art on society, demonstrate it, then why would a research-based, evidence-based institution like the medical world find any way to care deeply about what we all here on this stage at least know to be a really important approach to the questions of death and dying?
Thank you. Thank you all for bringing such dignity to the question, and we're going to wrap up with Dr. Feinberg coming back up to give some closing remarks.
Thank you very much. Please join me in thanking all of our panelists tremendously.